Okay. All right, so sorry about what happened. Obviously, that was beyond my control. Thanks for moving along with me so that we can preserve your time, which is very precious. Now let's get to some really good stuff. This is the EFAST, all right? The Extended Focused Assessment of Sonography and Trauma. So it used to just be the FAST exam. That's before we did the extended portion, all right? And what did that entail? Anybody? Okay, right upper quadrant. Left upper quadrant. Bladder. And subxiphoid, right? Okay, the pneumothorax was the E part of the extended FAST exam. They added it later. Okay, that stands for extended. So sometimes you just do the FAST exam, but almost always now we do the EFAST. And when is it most useful to do an EFAST exam? What kind of patient? Trauma. What kind of trauma? Blunt trauma. It's usually better for blood. Of course, we'll do it for penetrating as well because we can answer questions like, is there a pneumothorax? But it's the main indication for an EFAST is unequivocal, or for whatever reason, hypotension of a patient. We don't understand why they're hypotense. We're trying to figure out what is their their shock state. All right, what is causing the shocky state of the patient? All right, so that's an EFAST. So I'm going to shut this door and play a video. Oh, maybe. Great timing. That was awesome. Okay, so EFAST. All right, so let's watch this. Stupid. Sorry. Stupid. You don't know how to get that off. I did it. It is a CC button? I'm not qualified to teach you. I fired myself. Okay. Oh, whatever. Okay, somebody help me get this stupid thing off my computer, please.
Bro, I have no idea.
I can't even see F6. Alright, thank you whoever is so smart. Okay. Okay, as your confidence in me is dwindling by the moment, this is a real patient encounter. So that was an IED blast. It's a 22-year-old male. Had penetrating ball-bearing IED blasts in a pre-hospital environment downrange. He's arriving to the Roll 3. He had a pulse en route, but once he arrived to the Roll 3 facility, had lost vital signs. All right, and so that matters, right? So en route, the helicopter actually had an ultrasound machine. And en route, this is what it looked like, okay? That's the heart, and what do we see around the heart? What's that? It's a huge pericardial effusion from that penetrating trauma. So the right ventricle is collapsing during diastole. This is tamponade, all right? So that's why the patient lost vital signs, because he had tamponade to the point that it caused the heart to stop. Okay, so guess what they had to do? Now that the patient just died, what do we have to do medically? A thoracotomy, right? We have to crack the chest open because the patient just died. They had vital signs, now they don't, and you're going to learn this again in block 4 of EMED and block 3 of surgery. Now, once they've died, you have to do a thoracotomy. It's not any kind of ultrasound-guided pericardiocentesis, even though we know that it was a pericardial effusion causing tamponade. But now, once they died, you got to crack the chest open. And so this is an actual thoracotomy video of them cracking the chest open on the left side. They're trying to get to the pericardium to make a pericardial window to relieve the tamponade, and they're also packing the other vessels that were injured during this ball-bearing IED blast. All right? So pretty severe stuff. Do we agree? That's pretty crazy stuff. Pack, pack, pack. Not a sterile procedure. How many people go on to survive an ED thoracotomy and live? Very few, okay? I had the misfortune of one of my tours to Afghanistan. I was with the Roll 3. We did 17 ED thoracotomies during that 1 year when I was with the Marines. We were the first MEF Marines on Marines trying to save them. and only one lived. So a couple we got out of theater to lawn stool, but they ended up getting septic. Most of them went on and unfortunately passed away, but one triple amputee patient survived and was able to throw a pitch at the World Series, which is pretty phenomenal. So it's a futile effort. We do it after they've died, and we're doing everything we can to make them undie, okay, because they're dead. Okay, so the most clinical application for EFAS is in unstable trauma patients, usually from blunt trauma, but it can also be penetrating trauma, but it's most helpful in blunt trauma because we don't know which organ is injured. We kind of have an idea of what might be injured in a penetrating trauma, right? There's a big hole in the chest, okay? It's probably a chest wound, right? There's an abdominal evisceration, okay? That's a penetrating wound. We know that the bowel is involved. But for blunt trauma, which is multi-system blunt trauma like motor vehicle accidents, we don't know what's injured. We don't know why they're hypotense. Do they have a neurological injury? Or they have an intra-abdominal bleeding? Do they have a tamponade? Or they have a hemothorax? Do they have a pneumothorax or a tension pneumo? So these are all the questions we're asking. So, what's our clinical questions?
Is there bleeding?
Yeah, where?
In the body.
Yeah, okay, anywhere would be great, but we're not doing legs and stuff, right? But you're absolutely right. We're asking, is there hemoperitoneum? Okay, is there blood anywhere in the stomach? All right, or in the abdominal cavity? Is there a hemothorax? All right, is there pericardial fluid or bleed around the pericardium? Right, these are the questions we're asking. Okay, is there hemoperitoneum, hemothorax, hemopericardium, which is the same thing? And is there a pneumothorax, right? Or specifically, is there one and is there tension pathology, okay? So that's what we're asking. So what are the advantages of ultrasound? Well, it can be rapidly performed. It should take you no more than 4 minutes to do a bedside EFAS. 4 minutes, okay? Your time. I'm just kidding, okay? We actually give you a lot of grace with it because it takes a while to get, and sometimes even I today will struggle in the trauma bay. It's very hectic, everyone's yelling, everyone's around the patient, we got our clavicles up first, we got a right side, left side person, all of a sudden you see one person with an arm and an ultrasound probe trying to get around everybody to do the EFAS. So it's not the most ideal time, but it's an important bedside thing that we do. And why is this most useful in hypotense patients? Because we can't send them to CT. They're unstable. If you send them to CT, that's where they go and code and die. So this is it. This and quick chest and AP pelvis is all the images that we can do. All right, this is it. So that's why. It's non-invasive, there's no radiation, it can be rapidly performed. We can do serial exams. I've done fast exams on patients that have blood trauma that maybe the surgical suite downrange was occupied, they're already operating on somebody. And I do serial exams, negative, 10 minutes later, positive. You know, so you can do serial exams, which are important. Okay. All right, so what are some limitations, do you think? I mean, it says, all you gotta do is just work with me here, okay? This kind of helps sister out up here. Okay, so it does not assess for solid organ injury. What does that mean? I can't tell you, there's a grade 2 splenic laceration, like a CT can. It can't tell you that. It can't tell you if the hollow viscus or if there's a hollow viscus injury. Okay, CT can barely tell you that sometimes. An ultrasound certainly cannot. It can't tell you what type of free fluid it is, right? It can't differentiate blood versus ascites. I'm here to tell you, if you have a ascites patient that has blunt trauma, they come in the ER and they're hypotense, their FAST exam is always going to be positive because they're cirrhotic and they have ascites and it looks like right upper quadrant fluid. You can't differentiate, so that's a disadvantage. And then its sensitivity is operator dependent. So the better you are, the better and closer up to 100% accurate, sensitive and specific this exam can be. This is why I emphasize put your hands on the machine, practice, 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 because it's going to make you really good at it. Okay? So hemothorax and hemoperitoneum, we actually see all of this in the right upper quadrant view. And just this one view with my ultrasound probe here in the right upper quadrant, we're seeing this up here. This is liver. I know I couldn't point last time. This is liver. This is kidney. This right here is just let me orient you a little bit better. When you're looking at this view, the probe marker is up here. See that little dot? That's the probe marker up here. My probe marker when I'm doing this to the patient is towards the patient's head. All right? The patient's head is this way. If this is the patient's liver and kidney, the head is over here chest cavity somewhere here. Now there's their liver and kidney. And what else can you see in this image? Do you see any other organs or? You can kind of see the edge of the diaphragm here, right here, okay, towards the patient's head. So we can see the caudal tip or the inferior tip of the liver, which is important because that's where fluid will collect first, no matter where you're injured. That's the most dependent portion of the body. That being said, I've seen only left upper quadrant positive EFAST before, or positive FAST exams. So, but right upper quadrant is where it's going to collect first most of the time. So caudal tip or inferior pole of the kidney, then Morrison's pouch, then it starts collecting up here above the liver, underneath the diaphragm, and then what is that mirror thing that we're looking for that is good? If you did your image and actually went a little deeper, you would actually see the diaphragm and then see the mirroring artifact of the liver, which is a good sign. That means there's not a hemothorax, okay? You with me? I asked that a lot, right? Okay, because I really need you to be with me. Okay, so left upper quadrant is very similar to the right upper quadrant. There's a big organ and a kidney, and there's potential space in between, and that's how where the fluid collects. It collects in these potential spaces. Normally, the visceral pleura or whatever, or their lining, lines the organs. And when they come together, the kidney and the liver, or the kidney here and the spleen, it looks hyperechoic or white. Where those two visceral layers are touching each other, it looks white. They're not adhered to one another, theoretically. The right upper quadrant is not. There is actually a ligament that does adhere the kidney to the spleen on the left side. So on the right side, blood will collect here first, okay? On the left side, it's going to collect up here above the spleen first, because the kidney is adhered by a ligament to the spleen, okay? All right, so very similar though. We're looking for the same thing on the left side. Blood in the potential space between the kidney here and the spleen, above the spleen and under the diaphragm, and we're looking for that mirror artifact of another spleen above the diaphragm, okay? And then also we want to see the inferior pole of the kidney, which you cannot see in this little video. Still with me? All right, this is going to be fun stuff. Now hemoperitoneum. So we're using the bladder as just an identifier. So what I typically do, if it's a blunt trauma, I'll do right upper quadrant, then left upper quadrant, then bladder, because I don't have to change my depth of my probe at all. It's already preset at 15 or 16 centimeters, and that's all the deep you have to be for those three. But once you get to the heart, you have to change your depth to 20 centimeters, 21, sometimes 23, depending on if they have a protuberant abdomen or not. Okay, so I do these three views first, unless somebody came in with that Bible study gone wrong with a knife fight, they get stabbed to the anterior chest. I'm probably going to start with the heart, right? So you're going to just use common sense of what you're looking for. Anyway, the bladder is just an organ of identification. We're not actually looking at the bladder in this, even though we are finding the bladder. So where's the bladder located? It's right over the pubis symphysis. So y'all, please wear your chones, okay, when we're doing this on each other. Wear your little underwear and stuff, because we're going to get pretty intimate, okay? You're right on each other's symphysis, pubis bones, and so just be aware of that, be cognizant. Also, when we do the DVT studies, we're way up into the inguinal crease, so just kind of be sensitive to each other. We want to get close and personal, but not too close and personal, you know what I mean? So anyway, when we're doing the bladder view, we're doing it in 2 dimensions, okay? We're doing it transverse and sagittal, right over the pubis symphysis, and we're using the bladder as an identification organ. But what we're looking for is a wedge-shaped fluid collection outside of the bladder, where it's not supposed to be. So we all agree that looks like a bladder? Does anybody know if this is transverse or sagittal? Estimate sagittal. Sagittal pelvis. So that just means that instead of the probe marker being to the patient's right, the probe marker is to the patient's up. But we do it in two views of the bladder because it's kind of a 3-dimensional organ, if that makes sense. But anyway, we're just looking for fluid. So we're asking, is there a hemoperitoneum? And then lastly, is there a hemopericardium? So in a subxiphoid view, yes? I'm sorry, we asked that again. I was a little, I have no idea what's happening in this place. It's haunted today or something. I'm sorry, so I really didn't hear the first part. I probably won't hear it again.
The previous imaging of the bladder, obviously that was a healthy bladder. Where would the blood go? Would it be above?
I'm going to show you. I'm so glad you asked that because I'm going to show you. It's going to be wedge-shaped outside of the bladder walls. Usually, if you're looking at the image to the left side, but I'll show you what I'm talking about in just a moment. I'm so happy you asked that. So this is a subxiphoid view. It's also known as a subcostal view because you're underneath the costal area. And usually when I'm holding my probe like this. So right upper quadrant, left upper quadrant, bladder. But when you do the subxiphoid view, and I'm going to demo this, you actually need to let go, put your hands on top of the probe like so, and you're gonna have to get down underneath and actually push into the abdomen in order to get up under the heart to see it. So if your own hand is like this, you have a kung fu grip on your probe, you're gonna be blocking your own self from actually seeing the image correctly, and I will demo this. So anyway, just to orient you, this is a heart, okay? This is a right atrium right here. Right ventricle is that little guy at the top. It's on top because it's closest to the probe, okay? Remember where our heart is? Okay, so we see right atria, right ventricle closest to the probe, and the probe is here at the top. So we got right atria, right ventricle, left atria here, left ventricle. And you can see the pericardium all the way around it, we all agree? And so we're looking for black fluid collection in that pericardium. Now, is there any kind of physiologic fluid already in the pericardium?
Yes.
Yeah, it's about 25, 50 cc's. That just keeps the layer sliding without it. But if you see more than that, and I'll show you some examples in just a moment. Okay. And then lastly, pneumothorax. So we see it in real time. I'm putting the probe marker towards the patient's head. I'm getting at the second intercostal space, mid-clavicular line, in between two rib shadows, because ribs are going this way. I'm in between two ribs, right? And it's okay. This is awesome. Today is awesome. I don't know if does somebody have a voodoo doll or anything? Okay, anyway, I'm sorry. I for whatever I did. Okay, I'm sorry about yesterday. Okay, can we move on? Be better? Can we make up? Okay. Anyway, just kidding. So here's the pleural line, and again, we're looking at lung sliding. The visceral and parietal layers sliding against each other. If air is scattering that, then you're only going to see one layer, and it looks like it's not moving. Do you guys see that these things look like they're moving? That's that artifact that we are looking for. Some people call it marching ants or whatever. It's artifact. And then when we put our little line right over that pleural line in M mode, and this is what it should look like. You standing here, looking out at the sand and the water of the ocean, contemplating why you ever decided to come to IPAF, right? That's you. You're at the Sky Ocean Beach, right? Or seashore side, which is normal. If we don't see that, it's AB normal. So let's dive a little deeper in the radical quadrant. All right, y'all need a break?
No.
Are you matching my energy? I feel it. Okay, I feel it. Okay, good. All right, radical quadrant. So again, I'm over here, right where the liver and kidney kind of interface. Kidney's kind of retroperitoneal organ, right, kind of back here. And even though the ultrasound can't technically detect retroperitoneal injuries, they're referring to specifically pancreatic and duodenal injuries, okay? You can see the kidneys. We use it all the time and looking at the kidneys, looking for hydro, stuff like that. So anyway, radical quadrant, probe marker here is towards the patient's head, okay? I'm kind of in the anterior axillary, sometimes you gotta be in mid-axillary line, just to put it in perspective, and you're kind of back here like so. So anyhow, this is what we see when the ultrasound beams go into the body, and it's bouncing sound waves off this liver. Some of your livers look much bigger. That goes all the way around. Just saying, okay? And then kidney, all right? We're looking at that potential space. So this is what it should look like when we're looking at the image. This is where my probe marker is. This is what we see. We see liver. This is just portal veins and stuff in the liver, okay? This is just vasculature within the liver. Then we see the entire kidney. We see diaphragm. And what we should also see is the spine. The literal spine back here, and I'll show you in another image, but you'll see spine, and we call that the spine sign. And we're specifically looking at the inferior pole of the kidney or the caudal tip of the liver. We got to see both, because that's where blood will collect first during a trauma. Remember we said that in the radical quadrant? Next is Morrison's pouch, which is the potential space between the kidney and the liver. Then up here under the diaphragm, then above the diaphragm, we should see a mirror artifact. So we need to see the spine. So sometimes you'll have to do this in several images. It's almost unusual to get everything in one beautiful image, okay? You usually have to kind of slide the probe a little bit. So you get one area where you can see liver and kidney, and you're just sliding up towards the head, and you're sliding down. You're not moving anterior or posterior, you're just sliding up and down, okay? All right, so moving on. Okay, this is just a diagram of everything we're seeing. Does it make sense to you? Do you see it when you see that image? Does it look like that to you? It takes time sometimes. Yeah, I mean, really it does. I mean, when I first started doing ultrasound, I sucked at it. I really did. I sucked at it. I'm telling you, I didn't have blocks as a kid. I didn't understand any of it. I didn't have this kind of instruction either. They kind of just like, here's a machine, here's like 2 hours of training for everything, and you go do 50 exams of everything, and I sucked at it. And I, still sometimes can get disoriented. It took me a while to really understand, and that's what that muscle memory just comes in, where we're gonna do more and more reps. But you guys are gonna get really good at this, I promise. The previous classes, they love it. I keep getting emails from people, hey, thank you, I just did an EFAS on this person, you know, and it's a skill that you can take to phase 2, and then you can ask for credentials beyond that, which is awesome. So just to reorient you, the patient's head is right here, this way, because my probe marker's here. Anything north of that is the patient's head, okay? What's closest to my probe is the liver. Okay, this is my probe right here. This is liver. Okay, and then kind of further away is the kidney, which is here. You can see diaphragm. You see a little mirror artifact of the liver. You may not be able to appreciate it real great yet, and that's okay. We still got lots of training to do. And this is the patient's feet, so, or foot, if they only have one, which says foot. Okay, anyway, I don't know why it says that. Anyway, I guess the right foot. So we're looking distally, so I'm here. If I want to look distally and get to the inferior part of the kidney, which way, towards the feet or towards the head, do I need to slide my probe? I'm going inferior. The feet, right? Okay, so we're going to go that way. And we'll look at the inferior pole of the kidney, also known as the caudal tip of the liver. If I want to see up by the diaphragm, I'm going to slide up towards the head. So I can see diaphragm, and I can see up into the chest cavity. Okay, so it kind of makes sense where I'm going, right? All right. Okay, so you guys tell me, you be the judge. So we got caudal tip of the liver, kidney. This is Morrison's pouch. A little diaphragm action. You can actually see the spine down here. Those white things. I'm going to show you better images. Okay, I owe you better images than that. All right. Do you agree? You saw all those things together? Just take my word for it. Some of you. Okay. Did you guys see any black stuff that looked like fluid in any of that? Real quick. Yeah. Okay. There was none. You're correct. So this is a better image where we changed our depth. So we're a little closer to about 19. So now we see liver here, kidney, diaphragm. Now we can see the mirror image of that liver a little bit better above the diaphragm. It looks like this person has 2 livers, but they don't. And then we see the spine really good. Now in real life, our spine does not just stop magically at our diaphragm. We'd be pretty ridiculous looking if that happened, right? But just by the way the ultrasound is designed, you can't see the spine beyond the diaphragm because the air in the lungs is scattering the ultrasound images. So in a normal person, you'll see it look like this. You'll see liver, kidney, spine, and the spine will stop at the diaphragm. You know it's the diaphragm because you can have the patient take a deep breath. You see the diaphragm move. Okay, that's normal. If you see no mirror image of the liver and what we call a continuous spine sign, where the spine continues on above the diaphragm, that's a hemothorax. That's blood in the chest cavity, and that's bad. Okay, that's very bad. All right, you still with me? You don't need a break? Isn't this fascinating stuff? Sir?
Would a pleural effusion also give us similar sign, or is it just blood directly to the spine?
I can't hear you. I'm sorry, your mouth is below your thing. I can't.
If it was a significant pleural effusion, that would have a similar sign, correct?
It will. Blood's a little different because it's thicker and stuff, but you're absolutely correct. You can actually see fluid that way as well. It may not manifest as much as a continuous spine sign, but it does manifest. You're absolutely correct. Yep, absolutely. That's a great question. So right upper quadrant, how do we interpret it? First of all, blood will collect, where did I say first? Caudal tip of the liver or inferior pole. Then Morrison's pouch. Then up here above the liver but below the diaphragm, okay, for in the abdomen. That's the most dependent portion of our body, okay? So we're looking at 4 things when we look at the right upper quadrant. What 4 areas are we looking? Caudal tip of the liver, Morrison's pouch, between the diaphragm and the liver, good, and above the diaphragm and the chest. You're actually asking 4 clinical questions with just a right upper quadrant view. So anybody who's only been trained to look at Morrison's pouch, I hope this is sinking in. Okay, awesome. All right, moving on. Not very quickly, but I'm moving. Okay, what do y'all think? So we're looking at caudal tip of the liver. Look like is that normal? Yeah. Looks like there's something up in there, right? Looks like some fluid. All right, so that's a positive fast exam, and honestly, at that point, you're done. You don't have to do anything else. It's positive. Now, we probably want to know about their lung status. Maybe do the extended part. But as far as your question, is there a hemoperitoneum or any of those other areas? The answer is already yes. All right. Sometimes we'll go ahead and look just for giggles, and just they already know that this person needs to go to the OR, right? All right, what about this one? So there's so much fluid that not only is it around the caudal tip of the liver, it's so much it's starting to collect in Morrison's pouch now, which is that potential space between the kidney and the liver. Okay, you guys are awesome. What do y'all think about this? You know what, you guys didn't fall for it. This, instead of being right here, this person was up here and they're catching the gallbladder. So it could look like it's a false positive, that's actually gallbladder. Okay, so remember where you're at, make sure you see kidney with the liver, not just liver itself, okay? I can't even tell you how many times I've done that. So if you're splayed one way or the other too much, then you'll actually start seeing bowel, stomach, you'll see their bowels moving, stuff like that. You're like, okay, I need to adjust my image. Just remember where the kidneys are. We're looking at almost like CVA area. And for whatever reason, it's a little more posterior on the left side of everybody versus the right. The right's more anterior, probably because the side of the liver, right? Okay, so this is where you want to do. You want to do a dead shot right on it. Okay, moving on. What do y'all think? So we got kidney, caudal tip of the liver, spine sign. Too short of a video, let's go back. Does the spine stop at the diaphragm or keep going? I'll give you a better picture, don't I? Okay, let's see what else we got here. So that is actually here, and when I freeze the image, the spine is continuing beyond the diaphragm, which is here. This is a positive fast because there's a hemothorax here, so there's no mirror artifact of the liver, and the spine is continuing above the diaphragm, which is here. So it's hemothorax. All right, that was a tricky one. But we're going to keep doing these, okay? It'll be more obvious. Good thing you're not doing a written exam on this stuff, right? You know how hard it is to find good videos? Awesome. Okay. Now, some of you may be really proud of your own image acquisition, and there is a save button. One of the guys was so tickled with himself a few classes ago, I think he flooded the memory of all the machines with just pictures that he was so proud that he took. So anyway, there is a memory in these things, but they're short-lived. I'm not going to print them out or anything. Okay. All right, left upper quadrant, okay? So what 4 areas are we looking at the left upper quadrant? The inferior pole of the kidney, okay? Between the spleen and the kidney. It doesn't have like a person like Morrison that so humbly named the pouch after themselves. This side is just called the splenorenal recess, or the potential space between the kidney and the spleen, okay? So what else are we looking? Above the spleen but below the diaphragm, and then lastly, above the diaphragm for hemothorax, just like the right side, just smaller, and it's more posterior. That's it. You're just doing the exact same thing again. Okay, so just to orient you, spleen kind of looks like liver. As far as echogenicity, it's just significantly smaller, and in some of you, it's really small. All right, some people who are asplenic, there is no spleen, right? They had it removed, so keep that in mind. But when you're looking at the kidney, you want to see inferior pole. This is the feet of the patient. This is the head, diaphragm, spine sign. And then we'll actually see mirror artifact of the spleen, just like we did the liver, and that's normal. All right? Okay, let's do some images. All right, what do y'all think? We got all of spleen, the inferior pole of the kidney and the inferior spleen, potential space, diaphragm, and then it looks like there's some mirror imaging there. That's good. We're looking good. I didn't see anything obvious. All right, again, the fluid will collect here first on the left side, then in between. Okay, the reason why it doesn't in between first or down here first, it's more of this space, is because the kidney is adhered to the spleen by a ligament. All right, so it's a little more difficult for it to collect there. It still will if there's enough fluid, it just takes a little bit longer. Same thing that we did with the right upper quadrant. All right, so what do y'all think? Yeah, that's bad, right? That's totally positive. That's underneath the diaphragm, above the spleen, towards the patient's head. We've got the diaphragm, and there's definitely fluid there. And then down here's the spine. Doesn't look like there's a spine sign, so that means that there's not an associated hemothorax. This is just isolated hemoperitoneum. Okay? Let's do some more. What do y'all think? That's exactly correct. Somebody has, just like the other side where we started seeing the gallbladder, somebody came up too far onto the top of the patient. Now we're seeing bowel, we're seeing stomach, things like that. So that's not a good image. So that's not positive of anything except for normal bowel activity, okay? All right, what about this one? Not the the best image. This is a phased array, so it doesn't look as sharp. It depends on your machine. So just to orient you, this is diaphragm, this is spleen. Yeah, it's a lot of fluid. It's bad. All right, let's keep going. Suprapubic area. So to answer your question from earlier, sir, so what we're looking at is we're looking at transverse and sagittal views of the pelvis. We're getting right over the symphysis pubis, and we're going to use bladder as an identifier. So some of you, if you empty your bladder right before your friends ultrasound you, it's going to be a little harder to see. But it doesn't take that long to make at least a little bit of urine, all right? So this is what we look at. So we got the sagittal and transverse view. Transverse is like you're cutting it in half, so the probe markers to the patient's right. That's the image on the right, which is where I start first. My colleague, Kagan Williams, who will be here Thursday, who's taking over for Colonel Gendron. He's finishing the ultrasound fellowship. He likes to start sagittal, okay? And sometimes he'll get real into the weeds with ultrasound stuff because that's his specialty now. And so it's really important that we understand the basics. So if anything goes crazy on Thursday and you have questions or whatever, we'll catch back up. He's amazing. He's really good at it. He's going to be a great instructor here. Do you guys know him, Kagan Williams? Captain Williams? He's great. Okay, so I'm excited to have him come and join us. Anyway, you might actually inherit all 5 blocks of emergency medicine if I'm not employed October 28th. So anyway, that'd be fun. Anyway, so we're looking at the bladder as an identifier, and we're looking for wedge-shaped fluid densities outside of the bladder. And there's 2 distinct areas that collect fluid a little bit differently, whether you're male or female. Okay? So let's move on. Let's see about that. So this is what it looks like. So you take a guess, male or female? Female. This is a uterus, as you can see to the left of the bladder, and this is where women will collect fluid first in the pelvic area. It's called the pouch of Douglas. Some women have some physiologic free fluid, but this is also where we can look at, we can actually do an EFAS on a female if we think that they have a ruptured ectopic. It'll bleed into the peritoneum right down there in the pelvic area. Okay, so there's the uterus, and we're looking at the pouch of Douglas. Okay. And in men, it actually is the rectovesical pouch, okay, or the superior dome of the bladder. And I'll show you a picture of a positive male in just a moment. Female's rectouterine. So this is what it looks like. It's a wedge-shaped fluid collection outside of the bladder. See that? That's AV normal. Now sometimes we can think we see something that we don't. To me, the bladder is the most confusing because males have seminal vesicles. Females have ovaries sometimes that are really close to this area that maybe have a cyst. So sometimes it's less reliable. So just keep that in mind. So if you guys start seeing, have you guys diagnosed your own selves or your family members with anything since you've been at IPAP? Nobody? All the time? I mean, I know I did. I was like, I'm pretty sure you're dying of cancer. Okay. I just, a little bit of knowledge is dangerous, right? So anyway, ultrasound is something that you guys can do on each other, and sometimes you'll see fluid collections outside of that, and it's usually seminal vesicles or some free fluid. In this particular, this is a female patient, you actually see the IUD, okay? Sometimes you'll see tampons, you know, so this is kind of an intimate exam, so just keep that in mind. But please don't be like a few classes ago. I asked for a volunteer so I could do the EFAST, and a female ran up, she was like, I'm doing it, and she ran up here and took her shirt off so I could do the EFAST in front of everybody, and I got, you know, right upper quadrant, left upper quadrant. When I got to the pelvis, I saw a big baby head. And I was looking at her and I was like, did I just like, do you know? Like I was like looking at her, do you know? And she was smiling. I was like, hey, thanks for the heads up. You know? So I thought I just violated her, you know, HIPAA or something, but she wanted to tell the class she was pregnant by doing that, but didn't give me a heads up. So I just totally walked in it, right? So please don't do that if you're one of these people that. Anyway, you guys will see things on each other is my point. I was like, thanks a lot. She's like, I'm so happy. Everybody's clapped. It was a great day, and I was red. And I was anyway, she failed, okay? All right, so uterus, we'll see IUD sometimes, things like that. So, okay, moving on. To me, the bladders are hardest. Luckily, you guys will not be bleeding, and you guys will not identify a positive fast, hopefully. Okay, moving on. Subxiphoid or subcostal. It's exactly what it sounds like. It's underneath the xiphoid or underneath the costal margins of the chest. Some people's costal margins are really acute. Like they come together and it's like a point, and it's really hard to get the probe in there. Some people are super wide. You can put the whole curvilinear in there and it fits just nice, you know? Everyone's anatomy is just a little bit different. So when you guys are broken down into your groups, which are by squads, okay, which correlates with your group number, pick one patient that's going to be your patient for test day. Let's be smart, right? And no, you can't come with the patient mark with X's and stuff. Somebody tried that a few classes ago. I mean, that's a little obvious, but it actually helps us with turnaround time when we're testing. It also helps with decreased equipment use, like that gel and stuff. I mean, one class went through like 200 bottles of gel. I was like, what have y'all been doing? Okay, I don't know that we should leave you guys alone with the keys and the ultrasound probes and all the gel, because I don't know what they were ultrasounding, but we went through a lot of gel. Anyway, when we go back to the subxiphoid view, this is what it looks like, right? Closest to the probe, my probe marker to the right, we're gonna see liver and right atrium, right ventricle, and left atrium, left ventricle. And what's our clinical question looking at the heart? Yeah, is there a hemopericardium or fluid around the heart, right? So this is what it looks like if you're getting a good subxiphoid view. Y'all will have to learn 2 views of the heart. The subxiphoid, I spend like 5 seconds, and if I can't get a good subxiphoid view, I go right to peristernal long, right on top of the chest. I don't mess around, because there's so often you can't get a good subxiphoid. Some of y'all are super fit and muscular or small. Those folks are really easy. You can put a probe way down here and see their heart. You know, like everything comes in view. It's awesome. So I would highly recommend choosing that person for your group patient. But anyway, it doesn't mean that I do want you guys during practice though to switch out patients. Everybody gets in turns, because I want you to see different anatomy and the challenges with that. That's what's going to make you better. But for test day, let's keep it simple, right? We just all want to be successful. All right, I'm almost done. Okay, you're doing good. So that's a subxiphoid view. All right, and again, we're asking, is there a pericardium, and if hemopericardium, and if so, we want to see if the right ventricle is collapsing diastole, which means what? Tamponade physiology. You can't get that view. We're going to go to an alternate view called the peristernal long. So what do we see here? See the heart? We see fluid around the heart, and then what's happening here? Yeah, there's some tamponade physiology going on there. At one point, the ventricle is completely collapsing. It shouldn't completely collapse during diastole. Okay, so peristernal long is the alternate view, and you can always see the heart, no matter what their anatomy is on this view, because you're just going right in between the ribs. And this is the only time, remember I said, the probe marker is always to the patient's right or up. This is one of the few exceptions. And this is where the probe marker now is at the patient's left hip. So it's going to be kind of, you're cutting just off the sternum, 3rd or 4th intercostal space. So I usually go just above the nipple level. Okay, and then you're going to have the probe marker towards the patient's left hip, and you're going to cant the probe like so, cutting it, and I'm going to demo it. And this is what you see. So at the top, just to orient you, this is the same view that we would want to see for dilated cardiomyopathy, HOCM. This is the same view, right? We can diagnose so much stuff on this. At the top, just to orient you, closest to your probe is just the right ventricle. We cannot see the right atrium in this picture. Do I need to see the right atrium to diagnose a hemopericardium? No, because down here is the most dependent portion of the heart, where the left ventricle is. That's where it's going to collect first. So this whole thing here is the left ventricle. This is the aortic valve up here. You can kind of see it every now and then. This is the mitral valve between the left atria and left ventricle. So this is the mitral valve, this whole thing, ventricle, like we talked about last class. And then here's the left ventricular outflow tract that gets blocked with HOCM. So we can get that view really quick. Is there hemopericardium? No. And you can actually see the left ventricle and see if it's the right ventricle at the top, and see if it's collapsing to tell you if there's tamponade pathology. Okay, lastly, we're getting there, okay? All we're doing this afternoon or the next block is hands-on. We're gonna practice. We're gonna put our hands on each other and do some good ultrasounds. So lungs. Tell me what y'all see in this chest x-ray. Yeah, I mean, it looks very hyperechoic or, but nothing crazy, right? I mean, just not a very good image. Do y'all agree? This person has a 40% right-sided pneumothorax. Can't even see it. Yeah, if you're lucky on a chest x-ray, you'll see something subtle like a deep sulcus sign. But I can't even say this patient has it, but this is actually a positive pneumothorax. So AP single view lung sucks at diagnosing pneumothoraces, whereas bedside ultrasound is almost 100%, especially if you've done it a few times. So this is why we do it. It's more accurate. So what are we doing? We do bilateral lungs. Now why, on a pneumothorax, do I only need to do one little view, 2nd intercostal space, midclavicular line on the right? Yes, no. Then one more on the left, yes, no. Why do I only have to do that? Don't we have big lungs? Why don't I have to do it here? Yeah, so if you're supine, the air is going to rise, you only need to look at it one view. Now, if you really wanna know, and you're like, well, how big is the pneumothorax? You can slide down lung, rib by rib by rib until you can finally see functional lung. And where those two things meet, it's called lung point. We talked about that last block, right? Briefly? Too soon to talk about last block? Okay, just asking. Okay, so you're gonna kind of slide somewhere in the second to third intercostal space and then clavicular lines, same landmarks that we do for our needle decompression for tension pneumothorax. Okay, so this is 2 rib shadows, so I got rib here. Okay, the rib's up here, it's white, okay, but the shadow, nothing can go beyond it. Here's another rib with shadow. So we're looking at the pleural line in between, and we're looking for movement, that artifact. Do you guys see movement here? Does it look like they're moving like little marching ants, and every now and then you'll see like a ring down comet tail? You guys see that every now and then? It's a shimmering. That's normal. We want to see that. But sometimes our eyes deceive us. Sometimes people have broken ribs and they're splunting, they're not taking deep breaths, so you can't really see that pleural line moving too much. So then we go to M mode and we confirm our findings in our brightness mode. Okay, so there's the ribs, there's the rib shadows, there's a lung sliding. Okay, moving on. Okay, what do y'all think about this? I don't see marching ants, I don't really see movement. You see how it just looks static? That's because the air has separated the two linings and scattered the ultrasound beam at that point, so you can only see one layer. So to further confirm it, we're going to do the M mode, because we can't trust our eyes. We do it on both sides as part of the EFAS, we have to do it. All right, and this is what it should look like. So all you do on the same spot, you're just hitting the button M for M mode, aligning a line here along your pleural line, so you gotta make sure you get on the pleural line, which is here, and this is what you should see, Sky Ocean Beach is normal versus barcode, which is just one layer of the lining, which is AB normal or positive for pneumothorax. Okay, you guys already knew that. Okay, which one's normal? Yeah, you guys already knew this last block, right? This is why ultrasound should be first, don't you think? First block out of EMED? I think so too, I've been trying to change that. Okay, so there is that thing that if you kept sliding down, you would eventually catch good lung. And where you see bad lung, which is not moving, touching good lung that is moving is a term called lung point. This is 100% sensitive and specific for pneumothorax. So even though you might have already suspected it because you didn't see lung sliding, this is 100%. So anyway, here's lung sliding and here's no lung sliding. That's lung point. All right, that's where the bad and good lungs are coming together. All right, interpretation, lack of lung sliding or lung point, most specific. In summary, this is the thing, these are all the questions that we're asking, okay? And we're gonna practice this over and over and over and over. So you get the rest of the 2 hours whenever we meet again, whatever time we decide that is. I'm happy to start early, to practice, put your hands on. And then Thursday is gonna be another practice day of just EFAST. That's how much I want you guys to get multiple reps in. Before we take a break and everybody's ready and they're over it, just to orient you to how we have the class set up. This is station 1, I'm gonna turn the lights on. This is station 1, and this is station 2.